prognosis at that time. I knew the condition was terminal. But I wasn't supposed to survive for more than 10 days.
When you hear patients talking about dying, you just have to come to grips with the meaning of death for yourself. Those of us who work with dying patients and have taken part in the seminar on death and dying, which Dr. Ross began a few years ago, are all very much moved by the extraordinary openness and humanness and honesty we find there. It's very, very hard to deal with your own death before you have to. But all of us really ought to, because it has something to do with the quality of life. That's why Elizabeth Ross is a loved woman, a truly loved woman. She has, in a way, made something which is really natural all right again. I think she started us on a long journey.
When we talk about the fear of death, we should remember that most people are not afraid of falling asleep one day, of old age in bed, and just not waking up. But we are all afraid of a catastrophic death associated with pain, suffering, violence, and destructiveness. We know we really can't defend ourselves physically against the possibility of our death, so we defend ourselves psychologically. And naturally, the biggest and strongest defense is to deny that it really exists. We say, oh, it's not going to happen to me. We say it's going to happen to thee and to thee, but not to me. Many people are afraid of highways. If I'm afraid to use the Dan Ryan, and I just have to use it, what do? I'm not driving slow and carefully because that would give me more time to think about how frightening it is. So I deny that it's dangerous, and I put my foot a bit harder on the accelerator, and I look on the left and I look on the right, and I see a stalled car there and a police car there and an accident there, and each time I see those things, it kind of confirms in my mind, oh yes, it shall happen to thee and to thee, but not to me. And people who use this every day and get home safe without an accident, it confirms to them that they are immortal, that it shall not happen to them. This country especially is a death-denying society, and by this I mean that death and dying are no longer an acceptable part of life. In the old days, death came in different ways than it comes now. People died at home, in familiar surroundings with loved ones around them. Now more than half the people in this country die in hospitals, and this makes dying more impersonal and often more mechanical and dehumanized than it would be at home. The bigger and the better, the more sophisticated the hospitals are, the worse it is. We are so trained in medical schools to cure, to prolong life, to heal, but we don't stress enough that people also die and that the dying person also needs help.
Just tip a little bit there. Just tip it to the side one.
Not help to die, but help to live a human, dignified life until they died. And that is very hard to do in modern hospitals. Many times when a person is beyond medical help, they are put in a different room, they are left alone, they are very often isolated and lonely. And people say, well, what's the use of going in there? There's nothing much we can do. The staff feels very uncomfortable and doesn't know what to talk about. You can go in and talk about the beautiful weather outside next spring, but deep down in your soul you know that this person probably won't see next spring, and so it's a farce. What we are not teaching, and that's not only true for physicians, but nursing staff, social worker, hospital chaplains, is that these people have their own very specific needs. And most of them don't want to beat around the bush. They don't want to talk about jovial, trivial, superficial things, but they have very important things to talk about, namely what it's going to be like. They want to talk about death and dying, if only for 5 minutes. To bring out an unfinished business, to raise a question that's on their mind, And then afterwards it's okay again to talk about next spring. How difficult it is for the members of the helping profession to be comfortable with those patients. And I think if we can help people to realize that we're all finite and that death can be a very comfortable part of life and is not so horrifying and frightening as our fantasies. If we can help them sit and listen to dying patients, it doesn't only help the dying patient, but it helps the person who is comfortable doing that. We have talked with more than 400 terminally ill patients in order to find out what their real needs are and how we can best help them. We found out that most patients go through 5 stages in coming to terms with the fact that they are dying. And often their families and sometimes even the medical staff go through the same stages the patient does. When a patient is told that he has a serious illness, he first reacts with shock and denial. No, not me. We have seen patients maintaining their denial for months and months towards their family and towards their physician, and when we came in and asked them, how sick are you? Conveying to them that we don't need denial. They said, I'm full of cancer. Many, many times we have seen patients who said, I know I have cancer, but my family doesn't know. And the doctor says, I know he has cancer, but the patient doesn't know. And the family says, I know he has cancer, but don't tell him. And usually we ask the patient to convey to the family that he knows and that it's much better to talk about it frankly and open rather than to waste all the little remaining energy in playing a game. When a patient can no longer say, no, not me, his next question is usually, why me? And the patient gets angry and he questions why this is happening to him. He's angry at the people, he's angry at God. He raises his voice, he becomes very, very difficult management problem sometimes. He rings for the nurse all the time. He complains to the family about their visiting. Whatever you do is no good. We find that the more peppy, the more energetic, and in a way, the more effective you are, the more you get this patient's anger. They are angry at what you represent. If you come in full of life, energy, functioning, you rub in what this patient is in the process of losing. You make him aware that, yes, 2 weeks ago, I would walk around quick and peppy like this. I was able to work. I was able to go home to fix dinner for my children. I was able to do this and that, and look at me now. And they are angry about all the things they are in the process of losing, and they are angry at you only because you remind them of all the things that they were able to do. What we found most helpful to do with those patients is not to make them feel guilty and kind of convey to them that they are bad patients, but to kind of put yourself into the patient's shoes for a moment and say, you know, I think I would be angry too. Get it out, get it off your chest. I think it's a perfectly normal human reaction, and if you can get it off, maybe it helps you a little bit. Then the patient usually becomes less apprehensive, less difficult to manage and to handle and to tolerate. And he enters what we call the stage of bargaining. The bargaining, he's beginning to acknowledge, yes, me, but he adds a little word to it, but. And the but really means, maybe if I'm a good patient or a good Christian or I promise something, maybe I can live a little bit longer. And I think everybody needs this kind of truth, needs a little time of temporary peace, where you don't want to think about it, where you feel that you have a certain time, and the patient kind of recuperates to mobilize new energies for the final stages. When the bargaining time is up and he says, yes, me, but, when he drops the but, then he begins to really face, yes, it's me. And the patients then become depressed. I regard grief and depression in this period of time of a patient's life as very, very normal. What do we do when we come into a patient's room, patient who cries, especially if it's a man? Our tendency is to come in and try to cheer them up and say, oh, isn't it a lovely day outside, and cheer up, it's not so bad. For a patient who has the courage to face not only that he's losing one loved one, but everybody he has ever loved, and everything he has ever loved he has to separate himself from, is a very sad state of affairs. And he should be allowed to express this grief. He has to mourn not only the things he has already lost, which includes probably the job and the income and just to being at home with the family, which includes maybe an organ, maybe a breast, maybe a limb. But he goes then through the preparatory grief. That means he's beginning to separate himself from this earth. And that shows in a practical way in that he asks for all the friends to come and visit him once more. Then he would like to see his children once more. And then at the very end he only needs 1 or 2 people who are comfortable and who can sit in what we call the silence that goes beyond words. The silent companionship of a loved one, who can just sit and hold your hand or touch your hair or just be with you without words. A patient cannot reach this if he's not allowed to grieve. Stage of acceptance is not resignation. Resignation is kind of a bitter giving up, a defeat, what's the use? Acceptance is not a happy stage, but it's a feeling of, I have finished my unfinished business, I have done my best, I would like to lie back in my pillows now, and I'm ready for the last journey, if that's how people conceive of it. If you can help them through this, at the very end they have much less physical pain, they are at peace inside and outside. The family and the patient himself, when they reach the stage of acceptance of death together, it's really a kind of a victory. But it's hardest to reach this stage when we are dealing with the death of a child. Very, very small children naturally have absolutely no concept of death. They're only concerned about separation, and you try to have the parents, and if not both parents, at least the mother in with the children so that they're not alone. Later on, when they're about 3, 4, 5 years old, they begin to be very concerned about their body image, everything has to be intact. And so their biggest concern perhaps is at that time surgery or surgical procedures or doing anything that injures their body, and they have to talk about it. And so we talk about that, if that's relevant to them, and if that issue and question is raised by the child. The most important thing perhaps is that we listen to them, and when they ask a question that we don't tell them lies. We had a 7-year-old who was in a hospital, terminally ill with leukemia, and she went to the doctor and said, what is it like when I'm going to die? And he said, oh, I hear my page, and he left. And then she asked the nurse, and the nurse said, you're a bad girl, don't talk like this, you take your medicine, you get well. You see what this means is if you take your medicine, you will live and be well. And if you don't take your medicine and you talk like this, you're a bad girl and you're not going to get well. Which is a very punitive way of dealing with it. And then she asked our hospital chaplain the same question. And he looked at her and he said, what do you think it's going to be like? Which is a beautiful answer, because it says many things. It says, most important of all, yes, it may happen. But what do you think it's going to be like? And she looks at him like only a little girl can look at you, and she said, one of these days I'm going to fall asleep, and when I wake up, I'm with Jesus and my little sister. That simple. So children too, they know when they're dying. They have their own concept, depending on their age, and they can convey this to you if you can see it and hear it. And then you use their language, and in this way I think you can help them the most. In Kantonsspital in Zurich, in the hospital, they studied drawings of terminally ill children with inoperable brain tumors. And one boy drew a picture of a huge, huge cannon, and in front of the barrel was a tiny little boy, the diameter of the barrel, with a stop sign in his hand. And what this represents beautifully is our concept of death is a huge, destructive, powerful force that hits us from the outside and we can't do a thing about it. The tiny little boy with a stop sign standing in front of the hugest cannon for this tiny little boy. What you could tell to such a child is it must be terrible to feel so tiny and this thing here is so big. When this boy was able to talk about it, the next picture he made was a beautiful bird flying up into the sky, and everything was drawn in black and white except for his wing, which had a little touch of gold on the edge of the wing. And when asked what this was, he said, but naturally this is the peace bird flying up into the sky with a little bit of sunshine on my wing. And that was the day he died. Death is something you can't experiment with, you can't experience. So we in a hospital, who have to face death all the time and learn to deal with it, realize that the only way you can get the feeling of what it's like is to ask seriously ill patients themselves to be our teachers. How long have you been ill?
Oh,
About?
a brief period prior to that, very brief.
Only
in fact, I
brief
wasn't even aware of the fact that I was this ill until I collapsed on the street.
Yeah. What means this ill? How ill are you?
Well, gee, I wouldn't know how to define that.
What do you have?
Well, on top of the malignant growth, or...
You have a malignant growth?
I have a malignant growth on the right lung.
On the right lung? Yes. And you didn't know that until the beginning of this year?
No, I knew of this. I was aware of this, but I didn't know what else was wrong until I collapsed on the street. My legs gave way.
I see.
And I just fell.
You never, ever had to tell a patient that he had a serious illness. And you would never even dream of telling a patient he's dying anyway. But you can talk about dying. All our patients have told us that they were terminally ill and near their death. And this is irrelevant of the fact that they had been told or not told.
And this was the basic cause of the paralysis from the hip down.
How did you take it? How were you told that you had a malignancy?
Oh, I was aware of the malignancy, or suspected as much.
How? How do people know?
Feeling, instinct, I don't know. I just felt instinctively that this was the case. And
it was something bad. The other thing that patients always share with us is they would have liked to be told that it's serious, but they don't like to be told there's nothing else that can be done. If they are told that it's serious, they would like to be told with a glimpse of hope.
Even surgery couldn't have done it any good.
Couldn't have helped much.
Yes, but then he gave me some out by telling me that cobalt radiation could control it if it was effective with me.
How has your morale been since January?
Oh, fine. What are you going to do? I mean, you can't go crawl in the corner and beat your head against the wall and cry and pull your hair out.
I wish to be like you one day, if I ever have something like that.
Well, I can't think of any other attitude. I wouldn't know how else to approach it.
Your roommate has played a role.
Mr. Atkins, oh yes, he's been a terrific companion. He's with me constantly. He went home for 24 hours, and I thought I was lost. I had talking to myself, in fact, counting my fingers over and over again. Yeah, he's been quite a terrific companion.
Isn't that beautiful?
It certainly is.
It's lovely to watch, lovely to see on the ward.
Yeah.
I tend to think Mr. Atkins has a similar illness without...
I think that's pretty much what brought us together, our feeling for each other, knowing that we were both had terminal cases. And
does a shot of whiskey help once in a while?
yes, I wish I could get them more often.
That'll be taken care of.
Thank you, Doctor.
It's interesting. I didn't tell him what the biopsy results were. I came and told him that we had the biopsy results and we were transferring him to our ward for treatment.
As he was approaching, I said malignant.
Yeah.
And he said, yes. I mean, he wasn't a bit backward.
No, actually what he said was, he said it wasn't benign, wasn't it? I told him no, it wasn't.
So he helped you really talk about it.
Well, I've since learned that many residents or interns, now I understand too, amongst doctors, try to face away from the subject or do a discussion of the subject.
Very true. Do you know why?
This I don't understand either.
It's frightening for them. You see, as a physician, you're trained to cure and to treat. And it's very hard sometimes to face when you can't cure somebody anymore.
When Dr. Levine suggested to take a biopsy, I said, certainly, go ahead. Because I felt extremely secure in his hands, still do and always will.
That shows how important it is to have confidence in your
doctor-patient relationship. Terrific, terrific. There are many interns and many residents that still don't see this value.
They don't know.
No.
It's very hard to teach them. You said that you knew quite a while that you were a terminal patient.
Yes.
What does dying mean to you? I know that...
Nothing. I mean, everyone has to do it.
Do you have a special image about it,
No.
or is it just end?
No, just so it isn't a miserable end. As I told Dr. Levine, I wouldn't want to lay in agony for a long period of time.
Yeah. Is there anything afterwards?
Nothing that I fear.
Nothing?
No.
Nothing that you look forward to either?
No.
Thank you
Okay,
for
Doctor.
coming. Was it not too long to paint?
Oh, no, that doesn't bother me at all. Garrulous character to begin with.
And I hope that some of the things will help, perhaps, with relieving. If I hear you right, is a little bit of whiskey, good companionship, but not to be alone. I think you're a strong and a wise man. Good luck to you. Before we go into details, what was your gut reaction to this man? Do you remember what we talked about last time? What I mean by gut reaction? How do you feel towards this patient? Here, not up here.
I feel great admiration.
You admire him? What else?
I felt sorry.
Pity or sorry? What else?
I thought he was too accepting of it. I was suspicious of it.
You were suspicious of him?
I felt that he was using lovely words to conceal his real feelings.
Really?
That's up here. How did you feel?
I think that was my gut reaction.
What would you say? What would you call that in one word?
I don't know what the word
Phony?
No, I didn't
No?
think he was phony because he knew he was doing it.
He was disguising?
It was kind of denial.
Denial? I want as many as possible, and I'll tell you afterwards why. That's up here. That's an interpretation of a diagnosis. How do you feel here? It's very hard, but you have to learn to do that. Because it's what you feel here that the patient picks up, and that eventually helps in a relationship or doesn't help. He scared you? What else?
I think before he spoke, I felt very disturbed. I wanted to cry, but after hearing him, I felt strength in myself and felt resignation. I picked that up from him.
Who else had a gut reaction?
I felt like I wanted to get close to him, and he wouldn't let me. Now, like they were saying, he was talking, but I couldn't.
How did that make you feel?
It sort of made me angry.
Mm-hmm.
He himself said it was a defense mechanism. And I think he showed great fortitude in facing his situation, the way he's facing.
In one word, what was your gut reaction then?
He was brave. He's brave.
You admired him, you
I admire
envied
him for
him.
his bravery.
You see, the reason why I asked all this is that you admired him, you envied him, you pitied him, you were sad with him. The whole range of gut reactions with different people here. What we tried to learn, though, from them is what he was willing to share with us. It's not that you know everything, but that you're comfortable sometimes to say, I don't know. That you're willing to listen to your patient. And if you are assigned to such a man, and if you don't learn what your gut reaction is to a patient, what this patient does to me, you'll never quite know why you don't hit it off right. And it's a great art to elicit not only the patient's needs, but your own needs too and your own feelings. because those two, not up here, but those two gut reactions, will eventually result in either a very meaningful relationship or not a meaningful relationship. About a year ago, we had a 35-year-old black single girl who came to our hospital with the hope of getting treatment here. She was diagnosed having serious kidney disease. There are 2 programs here for indigent people. Both of them turned her down. And she came back to our hospital knowing that she had a short time to live. And that made it even more difficult because we knew that in our society we have means and ways of prolonging her life, but she couldn't afford it. The staff then, who could not accept this, they regarded her as a beautiful person, and they could not accept that this young woman had to die. She came to our seminar, and at the end she said very calmly, you know, I know I'm going to die very soon. When I die, it's just like going to be transplanted from this garden to the next garden. And I think my gut reaction at that time was that easy. And she looked at me and she said, no, it's not that easy. There is something that bothers me, but I can't put my finger on it. And she couldn't do it, and I think partially perhaps because it was a teaching seminar. So a few days later, and I had a strong urge to see her. And when I went to visit her, she had the same urgent need to what we call to finish unfinished business. So we sat together like 2 children searching in the dark for something we had lost, but not quite knowing what it was. And all she could say is, I'm bad, I'm bad, I'm bad. And we searched together, and finally she was able to say, you know, I've been calling God for help when things were bad, but I didn't call him when things were all right. What do you say to that, Dr. Ross? And I told her that children do this all the time. When they hurt, they go to mother, and when they're okay, they go their own merry way. And she looked with a happy, peaceful smile, and she said, you know, what you're saying is that this is human. And I nodded my head, and she was lying back in her pillows very peacefully. And then she did something that no other patient ever did before or afterwards. She looked at me and she said, what is your concept of death, Dr. Ross? And I looked at her, surprised, and then it dawned on me. You know, we always think it shall happen to thee and to thee, but not to me. And then I caught my breath, and I looked at her face, at this beautiful face, and I said, peace, and I really meant it. And she looked back at me with this beautiful smile, and she said, I'm going very peacefully now, from this garden to the next garden.